Look, and good morning, everybody, and thanks for your statements. Sounds positive enough, as you say. I'm just going to concentrate on one area today, is around medical cards and the eligibility and so forth. So, in 2014, there was a report by an expert panel on the medical need for medical card eligibility. Do you think there needs to be a review of that report, given, I suppose, the eligibility on medical grounds and the assessment of discretionary cards? And I understand probably about 10 to 12% of all medical cards are on discretionary grounds, but do you think there needs to be a review of that report that was done 10 years ago, if that's possible?
I'm not sure. The Secretary General wants to comment on the issue of whether or not a report needs to be updated or reviewed. In fairness, eligibility is determined by government, and we talked about that earlier in terms of the expansion. But I just, in terms of the discretionary piece and so on, I don't know, does Sean want to add any comment to that?
I haven't read the Keane report in a few years, so you've got me a little bit on the hop.
No problem, no problem.
But my memory of the Keane report was that it was effectively, the Keane report boiled down to that it was very challenging to award medical cards on anything other than a means test, other than a means basis without discretionary, because you got into a this wording may sound clumsy, so apologies if it does, but almost who was in the worst case position vis-a-vis different conditions. And I think my memory of the Keane report, actually, it's ironic, Anne-Marie was in charge rather than my memory of the Keane report was that it advised almost against awarding cards on the basis of medical conditions, but that felt that, notwithstanding all its challenges, that means testing was ultimately a reasonably fair approach. But means testing is fairly intrusive, and it's not a pleasant process for anyone to go through. No. And we recognise that, and we understand that. We try to make it as fair and compassionate as we can. But ultimately, it came down that when you in the round, means testing was probably the fairest approach. And one of the advantages, I suppose, of means testing is that, health. I'm a pharmacist by training, and my understanding is that a lot of health issues are related to people who are in lower socioeconomic groups and have less income. So there is an alignment with, you are targeting the medical cards towards the communities that most need them. And what we have done since then is we've tried to make the discretionary part of it more sensitive. We've tried to take learnings from that Keane report, and we've had various clinical advisory groups since then, 3 clinical advisory groups. We have a communications working group that works with stakeholders, has the Citizens Information services on it, has the Irish Hospice Foundation, the Cancer Society, and we try to listen to what people are telling us, and obviously the regional health forums and our engagements here, and we try to improve and standardise some of the discretionary bits. We've developed a burden of illness questionnaire that enables us to capture details that may not be as obvious, or costs that may not be as obvious on the initial medical card application form, but allows us to find those people who really should have a medical card, but on the first look of their income and outgoings, it isn't as clear. So we try to standardise our burden of illness process around that.
Sometimes the assessment can be extremely cold, to say the least, particularly on means. And I've just dealt with some individuals in my constituency, and it's kind of hard to listen to somebody that has a cancer diagnosis and they're over by €40. And obviously then there's a huge amount of, I suppose, overheads in relation to they've lost their job, and there's a huge amount of overheads that you wouldn't think about. This person wasn't thinking about this 1 year ago. Now they have all these overheads. And it just seems to be very cruel, that you have a system that's kind of arbitrary in relation to a discretionary medical cards.
Well, it tries not to be arbitrary, but the problem with a discretionary process is it is ultimately discretionary. But what we have tried to do is we've tried to standardise that. We've tried to develop systems that capture as much of the costs as we of medical conditions as possible. We do review, say, our burden of illness questionnaire that goes out from our medical officers to individuals. The Irish Cancer Society reports almost on an annual basis on the cost of cancer, and we try to make sure that the burden of illness questionnaire is capturing anything that the Irish that various studies have published, and we try to enhance that process all the time. Our medical officers look at that all the time. But look, I don't think I'd ever stand over and say that any means testing process isn't intrusive. And I can imagine that if someone has a cancer diagnosis, yes, that's it's hugely challenging to have to go through a means testing place around the time of diagnosis.
Applying and then appealing. And
I know. I absolutely acknowledge that, Deputy Kenny. I suppose what I should flag is we do have an emergency process, and what that does, where people, if there's a definitive need, if we can establish that somebody definitively needs a medical card to access services, but absolutely isn't in a position to deal with the means testing part of it at the time, they can apply for an emergency medical card. We give them a medical card, and when our medical officers, it's medically driven decision making. When our medical officers provide a recommendation for an emergency medical card, the individual gets a medical card. It is only for 6 months in that particular scenario, and we do the means test. We start the means test 3 months later, but if someone needs a medical card to access service urgently, we do have a process around that. Obviously, we do also have medical cards for scenarios where people are in end-of-life situations. The Minister introduced a medical card for people who were terminal diagnosis with a prognosis of 2 years. Look, again, that can be a difficult discussion for a clinician to have with a patient, because sometimes those discussions are iterative. People aren't, and with the way treatments have gone and therapies have gone recently, it can be very challenging to establish a prognosis. But as far as we can, we are trying to be as sensitive as we can to those things. And look, I absolutely recognise that it is a challenging process.
And is there any reason why, kind of, in the list of the appendix in relation to those that automatically qualify for a means card or means medical card, the terminal diagnosis is not on that list? Is there any reason?
No, it's just that we categorise that within the emergency scenarios. There's no reason. And to be honest, we have a communication working group that we work with stakeholders and healthcare campaigners, and so we're always looking at ways of enhancing access to the terminal medical card. And that would be
obviously reviewed over time, because obviously that's only changed in the last number of years.
2 years,
to diagnosis. And just finally on the kind of the issue around, I suppose, I don't know how you can define it, but how do you define discretionary? Is it kind of on the grounds of kind of medical need, or financial kind of, somebody that could be in a financial kind of situation that they just can't afford?
Okay, so in terms of the discretionary process, how that works through is, so you take someone through the normal means tested process, which involves an assessment of income and then outgoings on the other side. In the discretionary process, what we take in, we make a very, very substantial effort to try and identify all the healthcare costs that mightn't necessarily be clear. But ultimately, it still comes down to a means, in the main, it comes down to a means-based assessment. But we have, basically, if you want to put it, spread the net as wide as we possibly can to identify all the healthcare costs we can, and then make a decision. Then our medical officer are required to make a recommendation as to whether they think the medical costs are going to make it challenging in the context of the individual's income. So it is. Yeah,
and obviously medical costs that are accompanied to that diagnosis are quite substantial. When somebody basically has lost their job.
I think the indication, though, Deputy Kenny, of the intention to apply that fairly and apply it well is reflected in the fact that between medical cards and GP visit cards on a discretionary basis, there's over 200,000 of them in existence. So, I would say that's indicative of an attempt to capture every cost that a person is burdened by in relation to their healthcare when they don't meet the normal means test level.
I should say we also do look-backs and reviews, and if there are things that people can have bad experiences, we're very careful to look back and review our complaints. Are the things we could have done better? Are the things we need to include in our processes? Things we could have avoided in terms of challenges for individuals. So we do that on an ongoing basis. And Anne-Marie, when she was my predecessor, commenced a process where we got ISO accreditation, and part of that ISO accreditation is always looking out for opportunities for improvement and trying to improve the process all the time, trying to make it more sensitive. Yeah. But ultimately, as I say, I would never stand up and say it's not an obtrusive or intrusive process. Means testing by its nature is not nice when you're going through it, and I accept that. Albeit we try to put a compassion, and like some of that's reflecting our learnings from engagement with the political system, and plenty of feedback from TDs, senators, and councillors over the years around how we could improve and or where we could have done better.
And obviously, there, as I said from the outset, the 2014 report. I mean, it's nearly 10 years old, but hopefully that could be reviewed in the foreseeable future and look at how things can be done better, you know, because obviously times have moved on and so forth. Costs have moved on, you know, situations have moved on. But maybe at a future date that you may look at it again and review it and see can it be kind of just kind of tweaked in relation to kind of correspond to certain issues that kind of have risen, particularly around the cost of living. I think that's a huge issue now for the last few years for people that have a diagnosis that they've lost their job and then they can't get a medical card. Yeah. You know, and they're literally over by €50, and it's hard to hear somebody that's worked all their life and they're out by €50 and say, look, I can't afford this because I'm not eligible for a medical card. It's kind of difficult.
We do, as I say, we do try to capture all expenses and outgoings, and they're captured on a real-time basis. So if childcare has increased, that's captured on a real-time basis. If house insurance has increased or reduced, whichever way it goes, that's captured on a real-time basis. But sorry, I shouldn't be. Sorry, Bernard, I couldn't cross you.
No, that's okay.
Thanks. Thank you.